Everyone, welcome back to MEDICO DIY, and today in this video we'll be talking about metastatic bone tumors. By definition, metastatic bone tumors, it refers to those cancerous tumors which originate in other organs and involve the skeletal structures of the body. The skeleton, it is the third most common organ to be affected by metastatic cancer, following lungs and liver, which are the most common sites for the metastatic cancer to involve. And the metastatic bone tumors are more common than the primary bone tumors. Some of the tumors which involve the skeletal structures are carcinoma of the breast, carcinoma of the lungs, carcinoma of the prostate, kidney, thyroid, and adrenal neuroblastoma. In the females, the carcinoma of the breast is more common, while in the male, the carcinoma of the lungs is more common. And in children less than 6 years, adrenal neuroblastoma is more common. Now, different bones which are involved in metastatic tumors are ribs, spine, pelvis, femur, proximal half of the femur, and humerus, sternum, and skull. And it is uncommon below the elbow and the knee. The vertebra, it is the most common bone to be involved in metastatic tumors, and usually the thoracic vertebra are usually involved. In this picture, it shows most common site for the bone metastasis. Now, the pathway of the spread. Talking about the pathway of the spread, the metastatic tumors can involve the skeletal structures via direct invasion, via the bloodborne metastasis, or via the lymphatic. The lymphatic, it is very rare, and the bloodborne metastasis, it is the most common pathway by which it involves the skeletal structures. Like in prostate cancer, it involves the vertebra via the Batson's vertebral plexus, and in lung carcinoma and in renal carcinoma, it involves the vertebra or the other skeletal structures via the arterial spread. Now, talking about the factors which favors the bone metastasis are that the blood flow is high in the area of the red marrow. The tumor cells, they produce adhesive molecules that bind them to meristromal cells and the bone matrix. And the varieties of growth factors which are released and activated during the bone resorptions provide fertile ground in which the tumor cells can grow. Now, the bone lesions which are seen in the metastatic bone tumors are divided into three types: osteolytic variety, osteoblastic variety, and the lytic or blastic, that is the mixed variety. In the osteolytic variety, it is usually seen in thyroid cancers, melanoma, multiple myeloma, and the renal cancer. And the osteoblastic variety is usually seen in the prostate cancer. And talking about the mixed type, it is seen in the lung cancer or the breast cancer. And we can see that osteolytic variety is more frequent than the osteoblastic variety. And in the osteoblastic variety, there is pathological factors due to the poor quality of the bones produced by the osteoblast. In this picture, we can see that there is the lytic lesions are shown in the radiographic images by the black hole in the bone, while the blastic lesions are shown as the abnormal white area. Here in this picture, we can see that this is a normal, and these two pictures shows the metastatic involvement of the vertebra of the renal cell carcinoma metastasis to the lumbar vertebra. And here is the lytic lesions as shown by the black hole in the bone. And here there is a blastic lesions, that is abnormal white area, which is seen in prostate cancer on CT's blastic metastasis. In this picture also, we can see that here there is osteoblastic lesions seen in carcinoma of the prostate, and this is the bone scan where it shows multiple sites involvement, and this is also an osteolytic involvement in breast cancer, and here is the osteoblastic lesion in the prostate cancer. Talking about the clinical features, it usually involves an adult of age greater than 40 or 50 years. The patient may be asymptomatic or may be symptomatic. When the patient is asymptomatic, these findings are found accidentally on investigations done for some other reasons, or the patient may be symptomatic and the most common symptom being the pain. There can be pathological fractures as well, or there can be anemia, anorexia, nausea, general weakness, headache if the skull is involved. There can be girdle pain or spastic paralysis if the spine is involved. There can also be the collapse of the vertebra. If there is metastatic hypercalcemia, it is a medical emergency, and the patient presents with confusion, muscle weakness, polyuria, polydipsia, and nausea and vomiting. Sometimes there may be a patient who present for the first time with secondaries, that is with silent primary, like as those who are suffering from carcinoma of the thyroid or renal cell carcinoma or carcinoma of the bladder. Or the patient may be a known case of primary malignancy who presents with the features of bone metastasis. Talking about the investigation depends on whether it is a known case of primary tumors or the patient has presented for the first time with the secondary metastasis. If it is a known case of primary tumors, then according to the suspicion of where the bone can be involved, we can do plain X-ray or bone scan or PET scan. The plain X-ray shows osteolytic or osteoblastic lesions, or there can be pathological fractures as well. But bone scan is preferred in contrast to the plain X-ray, as the X-ray fails to detect about 20 to 25% of the metastatic lesions, or PET scan can also be done. If the patient has presented for the first time with secondary metastasis, then an effort should be made to find the primary tumor, and for that we will do the clinical investigations as well as other investigations. In clinical, depending upon the clinical examination, we will do the other investigations like USG abdomen or barium studies for the GIT malignancies, chest X-ray, CCT lungs, or thyroid scan for the lungs as well as for the thyroid tumors, and intravenous pyelogram for the renal carcinoma. The other investigations which we could do is CBC, which will show anemia. The ESR will be raised. Serum calcium, serum alkaline phosphatase, and serum acid phosphatase will also be raised. This serum acid phosphatase is typically raised in prostate cancer, and ultimately biopsy can also be done. In this picture, we can see that there is a pathological fracture, and the second picture shows that there is osteoblastic lesion. Here in this picture also we can see that here there is an osteolytic lesion in the femur in the case of metastasis in the femur. In the bone scan we can see that here in the right femur there is an osteolytic lesions. And in this second picture we can see that it is a case of prostate cancer metastasis in the vertebra. We can see that multiple sites are involved as well as the pelvis is also involved. Now, talking about the treatment is mainly symptomatic treatment for the pain, and bisphosphonates therapy can also be given, which prevents osteoclastic bone resorptions. For the prevention, we can also do measures to prevent the pathological fracture, and the prevention of the pathological fracture is more preferred than ultimately treating the pathological fractures, as there is shorter operative time, there is decreased morbidity, and there is quicker recovery. And for the control of the secondary, we can do by radiotherapy or chemotherapy. And if there is pathological fracture, then we can do internal fixation with acrylic cement. If there is hypercalcemia, then we can give cortisone. And for intractable pain, the ultimate treatment will be amputation. And if the life expectancy is less than 6 months, then palliative care is given. Talking about the prognosis, since the metastasis has already occurred, the prognosis is very poor. In lung carcinoma, the life expectancy, the survival rate is around 6 months, and for the breast cancer, it is around 24 months survival rate and the life expectancy rate, and in renal carcinoma, it is variable and may extend up to 6 months. Thank you so much for watching this video. Hope you like this video. Please do like, share, and subscribe, and stay tuned for more videos.